I'm Dr. Gopal Pillai,
Okay.
and I will be speaking today about inflammatory cytokines involved in recalcitrant diabetic macular edema. So we all know the pathogenesis of DME. It's like the breakdown of the blood-retinal barrier and increase in the vascular permeability because of loss of pericytes and altered retinal blood flow. And finally, it is one molecule, the molecule of 2000s, which is VEGF, the vascular endothelial growth factor, which is a central pillar in the development of fluid at the macula or hard exudates at the macula. So we have laser photocoagulation, we have intravitreal injection, we have a vitrectomy. These are the cornerstones of the management of diabetic macular edema. Now, recalcitrant diabetic macular edema is a little more different because you have treated this patient, and many of these patients are not having good results over a period of time in terms of poor visual gains or less reduction of macular edema or even persistence of macular edema or what we call resistance to treatment, which means more you inject also, nothing is happening. So that brings us to this question, whether it is VEGF-mediated macular edema in which anti-VEGF injections are not acting, or is it cytokine-mediated macular edema which may be amenable to steroids. So these are some of the studies which looked at which are the cytokines which are upregulated in diabetic macular edema, and you have seen a lot of these, these. And aqueous humor cytokine changes with anti-VEGF. With anti-VEGF, even though it reduces only the VEGF, it plays havoc within the environment, and that will change a lot of cytokines, and these are some of the studies which shows that as well. So we will look into vascular endothelial the role of VEGF is very well established. It's a pro-angiogenic factor which causes conformational change in the endothelial tight junctions, increasing the leakage. That is one of the mechanism of action. Placental growth factor is another cytokine which is potentially promotes angiogenesis just like VEGF and endothelial cell growth and proliferation. It binds to VEGFR1 which has higher affinity than actually VEGF. Another cytokine is platelet derived growth factor, and then we have interleukin 6 which is a marker for inflammation itself. In all the uveitis and all the inflammation across the body, interleukin 6 levels increases significantly. Interleukin 8 is there. It regulates endothelial permeability by down-regulating the tight junction proteins. Interleukin 10 and monocyte MCP1. That is again another thing, retinal ischemia and atherosclerosis, they will increase the expression of MCP1. It is lower in patients who responded well to treatment. Then we have interferon-inducible 10 kilodalton protein, intracellular adhesion molecule 1 which causes all the adhesions, the tumor necrosis factor TNF-alpha, etc. So this in mind, we did a study to actually look at what happens to the aqueous VEGF levels as well as the cytokine levels in patients who are responders and non-responders. So we had 40 patients in the study in which 1, 2, 3 injections were mandatory, and the 6th injection was also mandatory. The 4th and the 5th injection were PRN based on whether the patient had edema or not. And we looked at OCT, BCVA every month, etc. And aqueous was taken, and we categorized responders and non-responders based on these 3 criteria. We did not look at visual acuity because there are a lot of things which influence the visual acuity, including other things other than VEGF mediated. So macular thickness reduced more than 40% in the first 3 months. Our macular thickness is completely normalized in the first 3 months, which did not warrant a 4th or the 5th injection. If only these 4 injections were given in the total 6 months, so the 4th and the 5th month PRN dosage need not be given to those patients. If all these 3 were present, we told they were good responders. If all these 3 were negative, then we said they are poor responders. So it is not a cut in between, it is either side that we took in. And that is how we defined responders and non-responders. And then we looked at cytokines as well as aqueous levels, and let us go to the results. So you can see that the VEGF levels significantly dropped month after month after month. You can see that 1, 2, 3 months are mandatory, and so VEGF levels significantly reduced. And the 4th and the 5th month, basically, injection were given only to the non-responding group of patients, and that is why you can see that the VEGF is slightly higher. Now, this is the change in VEGF. And vision, this is logmar visual acuity, which kept on improving, and this is the change in visual acuity. Central macular thickness also significantly improved. you can see that the green is the responder and the brown is a non-responder. And you can see that the responders improved significantly in CMT as well as visual acuity, whereas the non-responders did not. So that is one thing. So this is the VEGF level which is at the baseline, and this is at the third injection. You can see that there is hardly any difference between the responder and the non-responder in terms of VEGF, which tells us that VEGF is something which is not responsible for the recalcitrants. And when you looked at the sixth injection, actually the responders were the ones which have more VEGF. All right. So then we had three groups, one with VEGF is very high, which was behaving a little different from the others. And then we looked at the cytokines. I'll just go to the results. Interleukin-6 was significantly high in non-responders. Interleukin-8 was significantly high in non-responders. IP-10 and MCP-1. These four things were significantly high, and this was published. And these were the protein differences between responders and non-responders. And the findings from the study had told us that VEGF reduces very well in both responders and non-responders. So the non-response or the recalcitrants is not because the VEGF is not reducing, but because the cytokines are higher in those patients. And that is how in those patients we may have to use corticosteroids or specific markers. Like we are moving into more personalized medicine, looking at what is happening inside each person. It's not diabetic macular edema as a whole and treating with one particular drug. So personalized medicine coming in. So we did Ozurdex and we looked at what are the changes in cytokines in the Ozurdex. So this is the visual acuity and central macular thickness improves, and these are the cytokines which reduce. You can see here that interleukin-6 was very high, which reduced significantly with Ozurdex. This is in the first 3 months, and this is later. So if you did not give Ozurdex in the first 3 months again, 3 monthly Ozurdex, you can see the surge of interleukin-6 from 342 to 1200. This is the reason why in Ozurdex probably there is some sort of a rebound edema if you do not treat in time. So in conclusion, the reason for variability is basically genetic, and VEGF and VEGFR polymorphism may regulate anti-VEGF, and alternate signaling mechanisms and protein candidates may need to be looked at. Thank you very much.
Thank you, sir, for enlightening us about the aqueous biomarkers. So is there any role of measuring the interleukin in systemically, because measuring them from the aqueous is invasive? So can we go systemically in the blood profile and measure them, and do they have any relation with that?
Yeah, a diabetic patient will have a lot of other problems, including leg ischemia. So systemic measure would be a very poor biomarker. But what we have also done, which I have not presented, is to try to correlate this invasive aqueous. See, invasive in the sense when you are giving an injection, at that point of time I may do paracentesis and take a 50 microliter of, so it's like a part of the intravitreal injection procedure itself. Other than that, we have never done the aqueous sampling. But what I have tried to correlate is to correlate the aqueous VEGF and cytokine levels with OCT biomarkers. And there are a lot of correlations with that. And so if you see this biomarker, we will think that, okay, this cytokine is rising. So that is something which I did not present today, but that is something which is there.
So if there are OCT biomarkers suggestive of recalcitrant DME,
yeah.
Do you?
So the type of edema, cystoid macular edema, is suggestive of inflammation. High reflective spots, increased number of hard exudates, loss of external limiting membrane. These are all drill. So these are all some of the markers for heightened inflammation.
If I'm just saying that if they are present and you can see that on the OCT, what is the way? Do we still get the aqueous markers done?
Aqueous biomarkers also is expensive, and so we do not regularly get it done in all patients. We have not reached a stage where we should do aqueous biomarkers in all patients. But the idea is to generate a kit where in the first injection itself, currently what is our paradigm? We inject the patient with 1, 2, 3, 4, 5, 6 anti-VEGF, and if it does not respond, then we will move to, maybe we'll move after 4 injections to another anti-VEGF and then only move to a steroid. But in the first injection itself, if you can take a drop of aqueous and put into a test, a kit, a bedside or a point of care testing kit, and we know whether cytokines are high or VEGF is high, you can take the decision of what drug you want to inject at the first injection itself. That's the advantage.
Sir, comparing the specificity of the aqueous biomarkers compared to the OCT biomarkers, what do you think? Which fare well? Like, it's quite obvious that the interleukins, which are directly measured from the aqueous, will be a more stringent biomarker than the biomarker that we see on the OCT. So, what do you think, sir?
Yeah. So a large number of testings are required to actually standardize the biomarkers and correlate them with aqueous biomarkers and OCT biomarkers. Large number of biomarkers are required. Large number of tests and sample size is required. That much sample size I do not have. So I agree with you that the specificity and spin sensitivity of the correlation is not very high. So I think future studies will require to do that.
Thank you, sir. An excellent talk.